Welcome to the second half of Plenary 1. I'm Dr. Pramod Sogani from New York City. Joining me on my right is Dr. Thomas Stinger from Florida. Our first speaker for this session is Dr. Martin A. Coyle. Dr. Martin Coyle is the Professor of Surgery and Head of Division of Urology at the Hospital for Sick Children in Toronto. He'll be addressing the highlights of the Society for Pediatric Urology program. Dr. Coyle?
Thank you, Dr. Sagani. Welcome, members and guests. It's an honor to be asked to present the highlights of the Society for Pediatric Urology. We spent the last 2 days at the Hilton Hotel engorging ourselves not only with culinary delights, but with new information related to pediatric urology. This was an excellent program that was organized, and kudos should be given to the program chairman, Dr. Andrew McNeely, for arranging a magnificent program. During the 2 days, we had 40 podium presentations, including 5 clinical and 5 research prize finalists. There were 29 moderated posters, 4 panels, 2 invited lectureships, the Meredith Campbell Lecture and the Society for Pediatric Urology Lecture, as well as a presidential address. We learned a lot about the history of New Orleans as well as Louisiana, but learned much more about urology. I think one thing we all gained was a sense of what humility and honesty truly are. One of our own members participated in a panel on exstrophy and was able to tell his story of his journey with exstrophy as a child, as a patient, as a physician, as a husband, and as a father. And to him, this was an exemplary act of courage to be able to stand up in front of us and give us his story and how we might have different conceptions and misconceptions about these children as they go on through life. One of the conundrums in pediatric surgery today in general has been the issue of anesthesia and its impact on the developing brain. Dr. John Heaton, who gave the Meredith Campbell Lecture, spoke on this interesting conundrum and really did not clear it for us completely. What he has said is essentially if you need surgery, it should be done because evidence is lacking to support a delay in surgery. Sedatives and analgesics should be given in appropriate doses in intervals because pain and stress can be deleterious. But he also said we should have an abundance of caution because if we can delay elective surgery beyond the period where the brain is undergoing rapid growth, that is in the first 3 to 5 years in life, and if we can achieve equivalent results, we should consider such a delay. So again, the answer is still ambiguous. The first clinical prize winner was by our program chairman and Dr. McNeely, who talked about the tethered cord syndrome. And this is where the normal conus is found on MRI. And in all cases, in this very structured, strict presentation, abnormal urodynamics were found. What they concluded was there was no objective difference in urologic outcome between the medical treatment, whether the phylum was sectioned or not, in patients who did have refractory dysfunctional voiding and where the conus position was normal. So this challenged our concept of dysfunctional voiding presumed to be secondary to a tethered phylum. We also had a research prize winner, and this came from the University of Colorado, looking at hypoxia-induced factors and their effect on the bladder and the kidneys. And essentially, this showed that by using an inhibitor of this pathway, we can alleviate partial bladder obstruction factors that are associated with deleterious effects on the kidneys and bladders. With regards to Dr. McNeely's presentation, another presentation was also given by the Duke group, which echoed his results. This was retrospective in nature, but also suggested the tethered cord release for the occult tethered cord is not really beneficial. There were 3 papers of note on sacral neuromodulation. 2 came from the Minneapolis group and Mayo Clinic. One looked at the fact that staged interstim placement is probably not necessary, as 98% of the time InterStim could be placed in one setting with lower anesthesia time, no increase in infections or compromise in outcome. However, this may be associated with insurance issues. The second paper from that group suggested that it might be considered in patients with refractory bowel bladder dysfunction. A third paper coming from Nashville looked at reoperation rate in children who have had sacral neuromodulation and showed that reoperation is most likely related to normal childhood activities, especially in children with low or subnormal basal or body mass indices. This was an interesting paper that came from Brazil looking at children in an enuresis clinic with monosynaptic enuresis where the parents and the children were evaluated separately. Unfortunately, all patients had received verbal punishment from their parents, and if there was a family history of enuresis, there was double the chance of the child undergoing physical punishment. A couple of papers on CORD were of interest. One looking at the GMS score, and this came from Atlanta, Georgia, where they showed it was really the penis itself, the structure, or CORD, that led to fistula as a complication rather than the position of the meatus. A second paper from the Miami group looked at dorsal plication versus division of the urethral plate with or without corporoplasty, and it suggested that there might be a reduction in length of the penis if one does plication only, where there may be an increase in length if the urethral plate is divided and corporoplasty performed. Some papers on the incised urethral plate. Urethroplasty suggested that there's a worse outcome in adults related to several variables. However, the Snodgrass and Bush group looked at glands as being the biggest predictor of problems, not the urethral width in sustaining urethroplasty complications. Dr. Keyes, also from the Texas group, looked at the PROM scorecard in patients who are greater than 10 years of age versus less than 10 years of age, depending on who the respondent was. And basically it showed that patients who came in after prior failed repair had dissatisfaction with penile appearance, voiding function, and deviated stream. There was a negative body perception, and teasing was common by peers in the older patients, and this led to the request for corrective surgery. A challenging paper came from the Houston group looking retrospectively at what had been a common operation, that is, using Byers flaps as a first stage of a planned hypospadias repair. What they found, however, that many of these children who underwent secondary hypospadias repair ultimately needed further surgery. They also found in their analysis that SIS was associated with an increased risk of complications. A real provoking paper came from Duke, where they looked at Dr. John Weiner's single surgeon experience with 452 one-stage hypospadias repairs over a 13-year period. He had excellent results where only 6% developed fistulae or glands dehiscence. However, their analysis suggested that continental anesthesia led to a fourfold increase in complication rate. Another paper from the Dallas group looked at a questionnaire in patients who were ready for transition to the adult population, and the biggest issues were really related to how these young adults would deal with health insurance coverage and financial issues, suggesting that a dedicated social worker and nurses were necessary in the transition process. A paper coming out of Cairo, Egypt, looked long-term at patients who had undergone exstrophy repair as children and found that they were socially and professionally successful. However, there were very distressing issues related to body image, which impacted sexual intercourse as well as integration with the opposite sex. Cosmetic acceptability was certainly not perfect, and this suggested that we continue to have long-term follow-up by a dedicated team. With regards to DSD, that may not be the term that we should use for patients with 46XX DSD or congenital adrenal hyperplasia, as Pappas has shown that this is not a term that's really enjoyed by many of this population. Likewise, the same group looked at voiding issues, and it suggested that a total urogenital mobilization may have a higher incidence of voiding dysfunction. There was a panel on socioeconomics where we learned that the Affordable Care Act is not perfect and may indeed have huge implications over the next 5 years. We learned in manpower there's now 29 pediatric urologic fellowship programs with 43 positions open, and there's a mixed interpretation as whether we're overproducing or underproducing pediatric urologists. We learned from 3 wise men as well as a scholarly moderator that experience is important and we have to learn from our history. We also learned from our president it's time to prove our quality as well as improve our quality and not to forget the patient experience. So quality improvement is most often accomplished by going in slow paces. What I learned 30 years ago when I finished my training is virtually obsolete now, and by step, we've changed how we practice medicine. So we'll see you again next year in San Diego, and just a gentle reminder that the senior authors are responsible for submitting their papers for publication.
Thank you, Dr. Call.